Today we will talk about the diabetes insipidus, the central, the nephrogenic, and the primary polydypsia. So we have to know the differences between these two because you're often asked in the question to differentiate between these. No, they're often confusing, so here we're just going to go through them, and hopefully it will help you at the end to get every question right on these questions. So the common features here are the polyuria, polydipsia, the urine osmolality is low, and the urine specific gravity is low. And so first, let's talk about the diabetes insipidus, the central, the nephrogenic. And in order to do that, let's just recap the basics. So the ADH is released. So this is the hypothalamus. This is the posterior pituitary. And here we have the supraoptic nucleus in the hypothalamus. And this is where the ADH is released from. And from the ADH, the nerve endings that then kind of release in the posterior pituitary. So now, in the central, what happens is that you have a disorder in the centrally, which means the brain, and so in the brain there is decreased ADH synthesis. So when the ADH levels decrease, that will cause a central deficiency. So it's basically just ADH deficiency. So what would be the causes for that? The causes for that would be, for example, if there is a tumor here that is destroying these nerves, or if there is a trauma here, or if there is, for example, infiltrative lesion, could be sarcoidosis, for example. So this would be the reason for decreased ADH or ADH deficiency. So now let's talk about what the effect of ADH is on what is the normal mechanism for ADH. So if the ADH is released from here, like in the collecting ducts, in the principal cells of the collecting duct, it actually acts and it opens up some channels called the aquaporins and the aquaporin 2 channels, and then those channels actually increase free water reabsorption. And the word free here is important because free water means that it is just free water. There are no electrolytes. And if there is, here we have the vessels, so in the collecting cells, principal cells, the aquaporin channels are opened, and then the free water is reabsorbed. And that if that free water is reabsorbed, what will happen here in the serum and what will happen here in the urine? So if there is increased free water in the vessels in the serum, obviously the osmolality will fall. Serum osmolality will fall, and the urine osmolality will be increased. But here we have a deficiency. So now if there is this was just a mechanism of how ADH normally functions, but what if there is deficiency of this? When there is deficiency of this, free water is not reabsorbed, and when free water is not reabsorbed, this osmolality is going to increase, right? This is the deficiency. The serum osmolality will increase, and in the urine osmolality is going to decrease because there is a lot of free water in the urine. And the urine specific gravity will also decrease, like right here. The urine osmolality is decreased, and the specific gravity is decreased because there's a lot of free water in the urine, because there is lack of ADH. And so if ADH, if there is so the reason for the specific gravity, low specific gravity, is because it's just free water, right? It does not contain any electrolytes, any glucose, any of the other electrolytes, sodium. So that's why the specific gravity is low. So that was the mechanism for central. Now what about the nephrogenic? So in nephrogenic, all of this mechanism here is intact. The CNS is intact, ADH is produced. But what happens is that that ADH is kind of it cannot function here. So in the collecting ducts. So then, so that is where the defect is. There is resistance, right? This is why it is called nephrogenic, because the kidneys actually are not responsive to the ADH. So the reasons for these are plenty. It could be electrolytes like hypercalcemia, or hypokalemia, or lithium, or CKD. Our important one is the mutation. There can be mutation here in the receptors for ADH. So that could be the reason. And then all the other features will be similar, right? If ADH is not working, then the free water will be excreted out in the urine, will not be reabsorbed, and the same mechanism will go on here in the nephrogenic as well. So now, in the primary polydypsia, we have increased water intake, and it usually occurs in the psychiatric condition. So in a psychiatric patient, they just drink a lot of water uncontrollably, and that actually causes problems. So in all of these conditions, increased free water intake and increased excretion of free water we will have the polyuria, and then polydypsia, because polyuria will cause increased thirst mechanism to get activated, and there is a polydypsia. So these are the common mechanisms, but these four are common to all of these three. So now we talked about the mechanisms, we talked about the causes. What about now ADH level? So what if you measure ADH level in the central one? The central, obviously, it will decrease because that is the reason for the disorder. In the nephrogenic, it will be normal or elevated because there is resistance. So the ADH, so the body may compensate by increasing ADH secretion. And here there is increased water. So whenever there is increased water intake and there is increased fluid, increased serum osmolality, it actually decreases the ADH level. So it can be either normal or it can actually decrease. Then serum osmolality. Serum osmolality we talked about. When there is no ADH, there will be no free water, and that would actually increase osmolality. So the serum is going to get concentrated because there is lack of water, because of the lack of ADH. Similar here, we have ADH does not work, but here the serum osmolality is actually going to decrease. And the reason is because you're drinking plenty of water, and that water is kind of getting to your bloodstream, and that is actually diluting the serum. So the serum osmolality here will fall. And I've written here the normal levels, so you can correlate in the question. If they give you like less than 275, you should think about primary polydypsia. If they give you more than 295, so you should think about the other two, the central and nephrogenic diabetes insipidus. So now let's talk about the water restriction test. So in this test, you restrict water intake for 2 to 3 hours, and then you check for the urine osmolality. So now, if in the central and the nephrogenic, because it's ADH defect, there is no. It's not like the patients are drinking plenty of water. That's not the primary pathology. The primary pathology is the ADH. So that's why water restriction is not going to do anything to the urine osmolality. So there will be no change in the urine osmolality in these two. But in primary polydypsia, obviously, it is going to significantly increase the urine osmolality because it is actually treating the cause, the increased water intake. So you restrict that water, and the urine osmolality will increase. Okay, so that will be like back to normal. The patient is going to be back to normal. So then, what about the desmopressin? So desmopressin is just like a synthetic ADH. So obviously, in central we have lack ADH. So if you give ADH, it is going to increase urine osmolality. And in the nephrogenic, it is not going to increase anything, or there will be no change because these patients have ADH, right? It's just that ADH is not functioning. And obviously here we'll have no change because polydypsia, we are not having ADH problem. And then the last one here, we are going to talk about the treatment. So in the treatment, obviously for ADH, for the ADH deficiency, we give desmopressin. For the central, we give desmopressin. And the nephrogenic, it depends on the cause, right? It depends on the cause. Correct the electrolytes, correct the CKD, stops or dose, or do some dose adjustments to the lithium. So that will be the treatment. You can actually give drugs like hydrochlorothiazide, so that will be diuretic, right? So now you might be thinking like the patient is excreting out, there is polyuria, so why the hell would you give hydrochlorothiazide? So it's actually paradoxical. So what hydrochlorothiazide does is that in the proximal tubule, it actually increases the free water reabsorption, so that you're not dependent on the lost on the collecting duct for reabsorption of that free water. So that's the paradox of hydrochlorothiazide. So paradox that can be given, amyloid can be given, and indomethacin can be given. So all of them have the similar mechanism here, increasing reabsorption in the proximal tubule. So then the last one here is the primary polydypsia. Why does it occur? Because of the increased water intake. So obviously just stop water. So restrict water. So that will be the treatment for primary polydypsia. So hope this was helpful. These are usually given in questions and often confusing, but if you know this table here, I can guarantee that you can get any question on the exam right.